Welcome to Deep in the Heart of Oz. Please pay attention to this lecture as there is a whole lot of information in it, and these are medications that you will be giving for the rest of your life. Thank you. Increased vascular stiffness in older adults causes a progressive increase in systolic blood pressure with advancing age, and that contributes to the development of left ventricular hypertrophy and altered diastolic filling. Contractility tends to decrease as a result of cardiac stiffness. Hypertension is vasoconstriction, and that can lead to increased risk of MI, or myocardial infarction, a heart attack, and CVA, or cerebral vascular accident, known as a stroke. The systolic and diastolic components of blood pressure are determined by cardiac output and total peripheral vascular resistance, and can be expressed by the product of the two. So blood pressure equals cardiac output times total peripheral resistance. The body maintains its blood pressure by adjusting the cardiac output to compensate for changes in peripheral vascular resistance. And it changes the peripheral vascular resistance to compensate for changes in cardiac output. Remember that electrical impulses from the SA node regulate the heart rate. Release of stress hormones and rigidity of the ventricular walls do not primarily influence blood pressure, but they can impact this secondarily. Venous disease is often related to preload, as there is a problem with returning blood to the heart. Remember, we talked about in pathophysiology, there's a lot of valves in the vein, so if they become incompetent, it's difficult to get that blood back to the heart. Cardiac output equals the blood that's pumped in a minute. SV, or stroke volume, is how much blood is ejected with each beat. Preload is the volume that stretches that ventricle with the filling at the end of diastole, or end diastolic filling, right before systole. Remember that hypertension can lead to increased risk of myocardial infarction and stroke. And so the big deal that we need to remember here is that we've got this number here shows 140 over 90 is a persistent number that's greater than that is defined as hypertension, but that's what your text is saying. If you're given different numbers in a different class, definitely go by that, because I know that the AHA has already made these numbers tighter, because we have found that this is the biggest cause for heart attack and stroke, and so we just keep tightening these numbers. And so we know that there is primary and essential, which we don't know what causes that. Sometimes you might hear that defined as idiopathic. And then we have the secondary, which is a result of an existing disease process. And so we're going to do everything we can to prevent heart attack and stroke. And so that's why we will be talking about that in both patho
Left
and
ventricular
pharmacology.
pressures increase with states that increase afterload of the heart, including systemic hypertension and aortic valve stenosis. Left ventricular radius increases in valvular heart disease, especially aortic regurgitation or cardiomyopathies causing systolic heart failure. Left ventricular wall thickness increases in chronic hypertension or aortic valve stenosis as a compensatory mechanism to decrease wall stress, inversely proportional to wall stress, thereby decreasing oxygen demand because the stress will be distributed over a larger mass. So hypertrophic obstructive cardiomyopathy, or an enlarged pooped out heart, will similarly increase wall thickness. And after a heart attack, the wall thins during the remodeling phase, which increases wall stress. So these are some examples of how wall tension, ventricular dilation, and ventricular radius will apply to hypertension with the law of Laplace. There are 7 categories of antihypertensives: diuretics,
Adrenergic drugs, vasodilators, angiotensin converting enzymes known as ACE inhibitors, angiotensin receptor blockers known as ARBs, calcium channel blockers or CCBs, and direct renin inhibitors. We have to do a little bit of a review on the nervous system. Hopefully this is just a review. The peripheral nervous system at the top includes the neurons and ganglia with the brain and the spinal cord. Remember, fight and flight, rest and digest with the autonomic or involuntary nervous system, and the somatic nervous system is the voluntary nervous system. We've already started talking about the sympathetic with the adrenergic and the parasympathetic with the cholinergic. With sympathetic, we talk about epinephrine, norepinephrine, and with parasympathetic, we'll talk about cholinergic, anticholinergic. And if you get those concepts early on, you're doing well, because we won't be talking about that for the rest of pharmacology. With the sympathetic nervous system, remember that we are having this whole fight or flight response with the increased blood pressure, the increased flow to the brain, heart and skeletal muscles. You're running through the woods from your murderer. Increased muscle glycogen for energy, increased rate of coagulation and pupil dilation, decreased flow to the viscera, also increased rate and depth of respiration, increased blood sugar, increased mental acuity, increased muscle strength. You know, we're like, got all this going on. So with adrenergic drugs, which we started talking about them with epinephrine with respiratory, we are going to talk about them with antihypertensives, and we will talk about neuron blockers with central and peripheral, alpha-2 receptor agonist. Remember, we're going to talk about agonist and antagonist. Agonist stimulate, antagonist block. And so you'll hear blockers, stimulators, you'll hear words kind of used interchangeably, so don't get lost in that. So with the central and peripheral neuron blockers, and then alpha-2 receptor agonist in the central, alpha-1 receptor blockers in the peripheral, beta receptor blockers in the peripheral, and then there's a combination alpha-1 and beta receptor blocker in the peripheral. There's this concept called first dose syncope that is associated with alpha adrenergic agonist, but I want you to know that, hey, guess what? It's kind of associated with any antihypertensive drug you'd ever give. I think this is a safety issue. I think anybody who's on an antihypertensive, especially for the first time, would be considered a fall risk. I think we should be doing orthostatic hypotension blood pressures on them, orthostatic blood pressures on them, because they need to set up on the side of the bed, dangle their feet. We need to go slow with them. We don't need to put them on 3 different blood pressure medications. We need to be looking at their medications in general. We need to watch them carefully, because this is a new thing for them, and they are a fall risk. And so they might wake up and be dizzy, and so if they hop out of bed, they might fall on their face. So this first dose syncope, that's what that is that they are on this brand new drug and they might be a little bit dizzy or shaky, and so we need to be aware of that. That's what that means. And I think it could apply to really any of these antihypertensives, and so that's a safety issue and a patient teaching issue. With the central nervous system, the stimulation of alpha-2 receptors is useful to help decrease the blood pressure, because it reduces sympathetic outflow, which decreases norepinephrine production. And most body tissues do have both alpha and beta receptors. This is secondary to receptor activated because of the number of the receptors in certain body tissues. And the effects to the kidneys are that it reduces renin, and that's a big thing for blood pressure, of course. Not surprisingly, there is a lot more that goes on with the peripheral nervous system. Alpha-1 blockers actually function to modify the sympathetic nervous system by blocking alpha-1 adrenergic receptors. If those receptors were stimulated, they would circulate norepinephrine and raise the blood pressure. But if it's blocked, it's lowered, because that would vasodilate. If it's vasodilated, it increases cardiac output. That also would help to increase urinary flow rates and decrease outflow obstruction by preventing the smooth muscle contraction in the bladder and the urethra, which helps benign prostatic hyperplasia. The dual action alpha-1 and beta receptor blockers work in the peripheral nervous system at the heart and blood vessel level. The beta-1 receptor portion decreases the heart rate, and the alpha-1 portion causes vasodilation. Your most common drugs in these classes are your alpha-2 adrenergic receptor stimulators, also known as agonists, clonidine, the other term is catapress, and methyledopa. Alpha-1 blockers are known as the osins because the suffix is osin, so you've got doxazosin, prazosin, tamsulosin, and terazosin. And then we've got the dual actions, alpha-1 and beta receptor blockers, as carvedilol and labetalol. Labetalol gets used in the ICU a lot. We will get into a separate class of beta blockers that have the suffix lol, but this is the dual actions. I wanted to give you a critical thinking question when we were in class. I don't think it's hard, but if your patient is wearing a clonidine or a catapress patch and is going down for an MRI, what should you do first? And what you should know is that a lot of these patches are made of metal. Not just clonidine and catapress, but even Nicoderm, nicotine patches, fentanyl patches. A lot of the patches have metal in them, so make sure you're taking off patches before people go down to their MRI so that they don't have problems in the MRI machine. That'd be good. No, it won't rip their arm off. There are some contraindications and side effects to these medications, and they go together. Contraindications are acute CHF, MAOIs, surprise, surprise, severe depression, peptic ulcers, severe kidney or liver disease. Adverse effects are bradycardia and reflex tachycardia because of the receptor sites that are being triggered. Bradycardia because we can lower the heart rate too much, and then because of the receptor sites we can actually cause a reflex tachycardia, believe it or not. Hypotension, because if we give too much we can actually cause hypotension. Dry mouth, drowsiness, and depression and dizziness are actually side effects because of what we are stimulating there. Edema because of the renin, and that is why severe kidney and CHF are contraindications. Constipation, peptic ulcer disease, and liver disease are don't go well because of the GI effects. Impotence is actually a major problem with a lot of antihypertensives because of how this works with the outflow with erections. So patients that are male are usually not very adherent with taking antihypertensives. So the rule of thumb is to try to let patients fail diet and exercise for 6 months prior to some on antihypertensives. Of course, this is dependent on what their actual blood pressure is, because if it is stroke and heart attack worthy, then we may have to start something sooner. Headache, of course, because of the vasodilation and constriction properties of the medications. ACE inhibitors and angiotensin II blockers are known as the prils and sartans, and they actually are clinically very similar drugs. So what you'll have to remember on these is the side effect differences. ACE inhibitors are known as the prils, and they block the production of angiotensin II, which is a very potent vasoconstrictor. And they block this vasoconstriction caused by angiotensin II, prevent aldosterone secretion so that
helps with sodium and water reabsorption, and they prevent the breakdown of bradykinin.
This is
which
just a little bit of a
vasodilator
story
to help you with Angie.
The ARBs
are known as the sartans.
Remember this story on
Angie?
Angiotensin 2 and her best friend Al.
And they block the binding of
Angie comes out to
angiotensin
play
at the
working
receptor
strict.
site, and the
She
end
calls her
result
best
is a
friend
decrease
Al,
in blood
aldosterone,
pressure, but
who
it's
causes
not
sodium
directly
and water
on the
retention.
angiotensin aldosterone
Together, these
mechanism
BFFs
like the prills.
cause a rise in blood pressure.
Clinically,
And
as
they
the do the
story
same thing
goes,
for hypertension.
when Angie
And both
and
Al are
pretty well
blocked
tolerated.
with ACE, but the
Sodium
ARBs, or
is
the
lost,
sartans,
and potassium is retained.
ARBs,
They don't
sodium
cause the
and
cough
potassium
or the
have an inverse
angioedema that the
relationship. Prills can sometimes. So ACE, contraindications and side effects. The big one is that you've got to have a normal potassium, 3.5 to 5. Yeah, I would expect you to know normal potassium range by now. A contraindication would be a potassium range that's higher than 5. Pregnancy is a contraindication. Lactating women or breastfeeding moms, contraindication. Children, contraindication. Bilateral renal artery stenosis would be a contraindication for ACE. Side effects, hyperkalemia. Oh, shocker. Hypotension. I wonder why that would happen. Angioedema, like we talked about. Fatigue, dizziness, headache, dry, non-productive cough, like we talked about. That's what makes it unique. Angioedema, cough. Neutropenia, thrombocytosis, and granulocytosis. But what makes it unique here is the hyperkalemia, angioedema, and the cough. That's what definitely makes ACE stand out and what you need to know. Got it? Good. Your suffix for ACE is pril. Hey, notice they all end that way, which is so handy. Catapril, benazepril, enalapril, moxapril, phenalapril, quinapril, ramipril, and trinalapril. Know the class. ACE inhibitors, pril, pril, pril. Got it? Good. Cough, angioedema. 3.5 to 5 is your potassium because it can cause hyperkalemia. Okie dokie. Now, a similar antihypertensive is your ARBs, or your angiotensin 2 receptor blockers. I like to call them ARB sartan Spartans. They block angiotensin 2 to type 1 angiotensin 2 receptors, and they primarily affect vascular smooth muscle and the adrenal gland. They block vasoconstriction and the secretion of aldosterone. Contraindications, also pregnancy and lactating women, and you have to use this cautiously with the elderly and anybody with renal dysfunction, so that part didn't change. Side effects, upper respiratory infection, headache, can also cause hyperkalemia, but it's not as common as it is with the ACE inhibitors. The cough and the angioedema is not a side effect. I know upper respiratory infection is, but cough and the angioedema isn't on here. So if a person has the cough and angioedema with the pril, we'll switch them over to an ARB, because clinically when they've tested them in the research, they work about the same. And the reason that we call them ARB sartan Spartan is because you will see the suffix here. Losartan, eposartan, valsartan, herbsartan, candesartan, olmesartan. Are you hearing me? We got that? Sartan is at the end there. So now you'll see sartan and you'll think ARB Spartan sartan. This is a miscellaneous antihypertensive slide, so this means I got this from your book because they had some interesting ones in there that I wanted to point out as an FYI. Elprone, or Inspra, is currently the only drug in a new class of antihypertensive drugs called selective aldosterone blockers. Bocentin, or Tracleer, works by blocking the receptors of the hormone endothelin. And treprostinil, or Remodulin, lowers blood pressure through a combined mechanism of action by dilating both pulmonary and systemic blood vessels and by inhibiting platelet aggregation, or sticky platelets. It's the only drug that to date is diluted by the nanogram. Haven't actually seen any of them used in practice, but I wanted to at least introduce you to them. Vasodilators is a class, and this one is super easy because they do exactly what they say. They vasodilate. They act directly on the arterial and venous smooth muscle to relax and reduce blood pressure. Common drugs are hydralazine or apresiline, minoxidil, diaxazide, or nipreside or nitropress. Contraindications, big one here, hypotension. Don't use it if somebody has low blood pressure. Cerebral edema, trauma to the head, acute MI, or coronary artery disease. I'm asking you to basically look at the adverse effects in the book on this one, but a big one to know on all of these, because it's a safety issue, is hypotension. That's something I definitely would want to know. As we have discussed, patient teaching is super important. We can talk all we want about pharmacological measures, but non-pharmacological measures are very important. Patients have to consume a diet low in fat, low in sodium. They need to be drinking more water. They need to be taking higher fiber. They need to be exercising. They need to decrease stress in their lives too. So these are all things that we need to be teaching as nurses. And I have a little bit of a case study for you, and you should know this one because I've talked about it already, but Tin Man was given a prescription for lisinopril a month ago. While taking his medication, he was between 130 and 138 on his systolic, and his diastolic was between 80 and 84. When he comes to the clinic, he says he's got a dry cough. It's driving him crazy, and he's been catching every cold that comes along, and he'd like to speak to the nurse about these complaints. Oh my, wonder what we could switch him. What does the nurse suspect is the cause of the cough? Well, I hope that you might be thinking it could be the fact that he's on this pril. Lisinopril is classified as an ACE inhibitor, and with the use of ACE inhibitors, a characteristic dry, non-productive cough may occur that is reversible once we stop taking it. It's theorized that ACE is responsible for the breakdown of bradykinin in the lungs, and when that breakdown is blocked by ACE, these substances can build up in the lungs, and that causes a chronic cough. Why does the nurse suspect that it is the cause of frequent infections? The nurse suspects that lisinopril has resulted in the adverse effect of neutropenia and agranulocytosis. With neutropenia and agranulocytosis, there are fewer white blood cells to fight off infection, and the patient has a risk for frequent infections. So we probably ought to switch him to a Spartan, right? Mikey Munchkin is a first-day post-op patient who has an abdominal aortic aneurysm repaired with a synthetic patch. He is sedated and is being monitored very closely to ensure his vital signs indicate adequate cardiac output and tissue perfusion, especially the kidneys. Why would he have the vasodilator sodium nipreside, nitropress, being titrated in a continuous drip? Well, we haven't talked about all of the different things with nitro, but we will. Nitro, he would be on this for his blood pressure. We did talk about aneurysms, and that would definitely, if he'd be in ICU, and if it's in glass, it'll have special coverings on it because it can turn into cyanide if it's exposed to sun. That's why if we see nitro tablets, you'll see it in a little brown bottle too. It can turn into cyanide. And so it's the same thing in the ICU, that it has to have special coverings, and even on the tubing. So but it acts directly on the arterial and venous smooth muscle to cause relaxation and keep that blood pressure low enough to prevent hypertension and the risk of blowing the graph. The reduction in systemic vascular resistance is important to maintain this new graph. Hypertension can obviously be lethal to this patient, and nipreside has both arterial wall and venous dilation effects and produces significant hypotension, so we're going to have to watch him both ways. The family asks why this medicine is wrapped in an aluminum foil. Whoops, I already told you.
Sodium nitroprusside is broken down into cyanide when exposed to sunlight. If the fluid turns a light blue, this is an indication that this has happened. The bag and tubing are kept out of the sun and changed every 24 hours. Cyanide ions are a byproduct of nitroprusside metabolism. Cyanide and thiocyanate toxicity are seen clinically when nitroprusside is used at high doses for long periods of time or in patients with renal insufficiency. So when nitroprusside is combined with sodium thiosulfate, the potential for cyanide toxicity is greatly reduced. So we certainly don't want to give our patient cyanide toxicity. Mikey develops bradycardia and petechiae on post-op day 3. How will the nurse explain these clinical developments to the family? Adverse effects of this medication include decreased heart rate, decreased platelet aggregation, rash, hypothyroidism, hypotension, methylglobinurinemia, that's a really hard one to say, and rarely cyanide toxicity. So we would have to explain the adverse effects of that particular medication. And so the petechiae is the bruising that they're seeing from the platelet aggregation, the decreased platelet aggregation, decreased platelet sticking, and then it can decrease the heart rate as well. We'll talk more about hypothyroidism later. And then the other has to do with muscles. Angina. When the heart's supply of blood carrying oxygen is insufficient to meet the demands, we get pain, that whole bradykinin thing, and angina pectoris or chest pain occurs. Ischemic heart disease, or MI, is the #1 killer in the U.S. today, and when the myocardium is deprived of O2 or oxygen, the heart shifts to anaerobic metabolism to meet the energy needs, and one of the byproducts is lactic acid, which builds up, and other metabolic byproducts cause pain receptors surrounding the heart to be stimulated, and which produces the pain known as angina. So how does nitro work for angina? Nitroglycerin produces its effects by releasing nitric oxide in vascular smooth muscle of the target tissues, resulting in relaxation of this muscle and increased blood flow. Because it vasodilates, it actually decreases preload. Chronic stable angina is caused by fixed coronary obstruction that produces an imbalance between coronary blood flow and the metabolic demands of the myocardium. If endothelial relaxing factors are present, they relax the smooth muscle in the vessel wall and allow increased blood flow, so there's no angina. Treatment for chronic stable angina is with a vasodilating agent such as nitroglycerin that relaxes the vessels and enhances coronary blood flow. Intermittent vessel vasospasms in conjunction with coronary artery stenosis cause vasospastic types of angina. Increased formation of collateral vessels is a compensatory response that we've talked about in patho that allows adequate blood circulation to the tissues distal to an obstruction. Now, one of the big things that does happen with nitro that you certainly need to remember is that if you touch it, you're going to get a headache. So make sure that you wear gloves. You will be highly tested on all of the different preparations of nitro. So you need to know about nitro paste. Nitro paste comes in a little box with paper, and you have to measure it, and then, you know, if you get told to put an inch of nitro paste on, the paper has measurements on it, and you measure it on there, and then you put it on the person's chest, and then you put plastic wrap over the chest. If it's sublingual tablets, that means it goes under the tongue. If it's a spray, then it usually gets sprayed under the tongue. If it's a patch, then it's going to be put on the skin. There's lots of different ways that this stuff can be given, and so you need to know that. And the reason that this is really important is because I have seen people try to put the paste under people's tongues, and that's not how that works. That's not how that works at all. Also, the
AHA gives guidelines now. These nitro pills or sublingual pills, it is still this way that you give one and then every 5 minutes up to 3. However, now they instruct people that after one is given, and if there's no relief after 5 minutes, go ahead and call 911. It was, take one, and then after 5 minutes, take another, and after 3, call 911. Now it's take one, and if there's no relief, you go ahead and call 911. So that's the new rule. So make sure that you know that. You'll hear it again. 3 main classes of drugs are nitrates, beta blockers, and calcium channel blockers. And we use nitrates a lot for prophylaxis and treatment of angina. And they are our vasodilators. And I think that's about enough for a start on that. Beta blockers, a little bit on beta blockers and calcium channel blockers. Any decrease in the energy bands in the heart is beneficial for alleviating conditions such as angina, so rest. So yeah, if anybody starts having chest pain, the first thing we want them to do is to lay down, relax. When beta receptors are blocked by beta blockers, the rate at which the SA node, or the pacemaker of the heart, fires decreases, and the time which it takes to recover increases. Beta blockers slow conduction through the AV node and reduce myocardial contractility. Both of these effects serve to slow the heart rate down. And these effects reduce oxygen demand, and that helps treat angina by reducing the workload. Again, if we're talking about chest pain protocol, we're talking about MONA, morphine, oxygen, nitro, and aspirin, right? So those same things, if we have oxygen available, we're trying to get that to somebody. Calcium also plays an important role in the excitation, contraction coupling process that occurs in the heart and vascular smooth muscle cells, as well as the skeletal muscle. Preventing calcium from entering into this process with calcium channel blockers prevents muscle contraction and promotes muscle relaxation. Relaxation of smooth muscle that surrounds the coronary arteries causes dilation, and that increases blood flow to ischemic heart muscle, which in turn increases oxygen supply, helps shift the supply and demand ratio back to normal, and helps with angina. Nitrates help dilate blood vessels, relax smooth muscle. They dilate the coronary arteries, reduce venous return, reduce preload, also known as the left ventricular end diastolic volume, and lower left ventricular pressure. You wouldn't give this for anemia. You can't give it for closed angle glaucoma. You have to really, really watch this with hypotension. You cannot give this for severe head injury, and you cannot give this to somebody using ED or erectile dysfunction drugs. There's a movie where they keep asking Jack Nicholson, Jack Nicholson, I said that backwards, I knew that didn't sound right. If he's using Viagra, and he's saying no, and then they finally are like, but you could die if you are. Yeah, I'm using Viagra. Well, the problem is that it can bottom out the blood pressure completely if somebody is using erectile dysfunction drugs and we give them nitro. So there's that. Adverse effects, headache. If you don't have any kind of problems and we give you nitro and it vasodilates, you're going to have a whopping headache. Hypotension. It causes vasodilation, so it can drop that blood pressure. And it can actually cause a reflex tachycardia. Common drugs, nitroglyceride, isorbide dinitrate or Izerdil, isorbide mononitrate or Imdur. The suffix is nitrate. Beta blockers, suffix is LOL. So yeah, this is the laugh out loud drug. Beta blockers. Beta 1 receptors are blocked and decrease the heart rate at which the SA node or the pacemaker fires. It slows conduction through the AV node and reduces myocardial contractility, slows the heart rate, reduces oxygen demand, and that helps with angina and workload on the heart muscle. It's contraindicated for patients who have systolic heart failure or if they have serious conduction disturbances because it's not going to work right for them. We have to use cautiously for patients who have asthma, diabetes, or PVD. The adverse effects: it blocks beta 1, and that can cause a decreased heart rate. It can decrease the cardiac output and decreases cardiac contractility. Blocking beta 2 can cause bronchoconstriction and increase airway resistance. So that could cause problems for people who have asthma. Beta blockers can lead to rhythm problems. So if they have conduction problems, decreased SA and AV node conduction would be an issue. Decreased blood pressure and decreased renin release. With diabetes, beta blockers can actually mask tachycardia with hypoglycemia, because that would be a symptom of hypoglycemia. They can also cause hyperglycemia in diabetes patients. So that is definitely something that's unique with the beta blocker, is that patients who have diabetes, it's not the best drug for them. Somebody who has diabetes on a beta blocker, it's hard for them to tell if they have hypoglycemia or hyperglycemia, or if it's a side effect of their drug. So that is why that's not a good one for them. Common drugs are atenolol, metoprolol, nadolol, or propanolol. Notice that the suffix is lol. So now and forever on, beta blockers are lols. Calcium channel blockers are used to treat angina, dysrhythmias, and hypertension, and to reduce blood pressure by causing smooth muscle relaxation, dilating blood vessels, and of course, if calcium isn't present, smooth muscle blood vessels can't contract. It blocks the calcium channels on peripheral vessels. Verapamil or Kalin, dilatism, cardism. Dilatism, cardism is definitely a CCB to know. Amlodipine or Norvasc, nifedipine, Procardia, that's a common one. But dilatism, cardism, verapamil, Kalin, those are calcium channel blockers to know. Contraindications: acute MI, second or third degree AV block, unless the person has a pacemaker. And of course, hypotension, that makes sense. Why would we want to lower somebody even more? Adverse effects: lowers the blood pressure, can cause palpitations, can cause tachycardia or bradycardia, can cause shortness of breath, can cause flushing, and can cause peripheral edema. We give calcium channel blockers sometimes for people who have a dysrhythmia like AFib with rapid ventricular rate. So we might give this for ventricular dysrhythmias. This is also an FYI slide. Ranolazine or Renoxa is a drug for chronic angina. Its mechanism is unknown. Unlike the others, it has an anti-ischemic effect that does not involve reductions in heart rate or blood pressure, but it is known to prolong the QT interval on EKG, and it is used when other anti-anginal agents have failed. And this was in your text, and it was a new one, so I just kind of wanted to put it out there as an FYI. The poor cowardly lion is a patient who has diabetes. He's been seen in the emergency department for jaw pain and crushing chest pain that began while he was pruning the bushes in front of his kingdom. The patient's diagnosed with angina, and the nurse administers the ordered aspirin and sublingual nitroglycerin, and the patient immediately has shortness of breath and breaks out in hives along his neck, chest, and upper arms. The patient is treated with oral diphenhydramine or Benadryl, an IV dexamethasone or Decadron, which is an anti-inflammatory steroid. Boy, got that out there. And he recovers without incidents. The Cowardly Lion tells the nurse that his wife had a heart attack last month, that his symptoms are much different with crushing chest pain. He asks the nurse how a problem with the heart can manifest as jaw pain and nausea instead of direct chest pain. How will the nurse respond? Well, as we have talked, we can have different symptoms. The nurse will teach the patient that angina can be manifested by a variety of symptoms depending on the area of the heart that is affected. Women often don't have the typical symptoms of an MI that men do. Chest pain occurs because of an interruption in blood supply to the myocardium or the heart muscle. This interruption can occur in any area of the heart where vessels feeding the heart experience narrowing and obstruction of blood flow. The nerves adjacent to that area respond to the hypoxia with pain, thus the location of the pain can vary. The patient asks the nurse, what am I going to do if I experience more chest pain? Isn't nitroglycerin the only medication that treats chest pain? How will the nurse respond? Nitrates, beta blockers, and calcium channel blockers may be used to treat the symptoms of angina. What is going on with congestive heart failure? Basically, this is a pooped or ineffective heart pump that causes the kidneys to get less blood flow, and because of this, they hold on to water and sodium, which leads to retention. The right is systemic with lower extremity edema, ascites, liver issues, abdominal pain, large abdomen. The left is lung with crackles, dyspnea, cyanosis. Having a patient weigh every day in the same clothes or in no clothes is one intervention that we use to monitor congestive heart failure. Monitoring intake and output is another. Those are tried and true methods that we use consistently. When we do start talking about diuretics, please remember that the best way for patients to take them is in the morning. Now, retention with shock is a little bit different and part of compensation. Why might there hardly be any output from a shock patient? Low blood pressure, high heart rate. No blood flow to vital organs, so the kidneys are trying to hold on to the urine. Continuous measure of urine output is essential for assessing the circulatory status of a person in shock. Oliguria of 20 milliliters an hour or less indicates inadequate renal perfusion. Continuous measurement of urine output is essential for assessing the circulatory and volume status of a person in shock and monitoring the response to fluid replacement. As shock progresses and blood flow to the brain decreases, restlessness is replaced by apathy and stupor. Sympathetic stimulation also leads to intense vasoconstriction of the skin, vessels, and activation of the sweat glands. As a result, the skin is cool and moist and diaphoretic. There is an increase in heart rate, cool and clammy skin, a decrease in arterial blood pressure, and if you've got a Foley catheter in, you'll see a decrease in urine output as well because they're holding on to what they have left. So basically with CHF, we've got a pooped pump, but I wanted to throw in a little bit about shock there as well. You absolutely need to know the terms inotropic, chronotropic, and dromotropic. You will be tested on those terms. And so we're going to talk about those and apply those. ACE inhibitors treat chronic CHF because of the way that they work on the renin-angiotensin-aldosterone system and the sympathetic nervous system. The drugs of choice at the start of therapy are the ACE inhibitors or the ARBs and certain beta blockers. Loop diuretics are used to reduce symptoms of congestive heart failure secondary to fluid overload, and the aldosterone inhibitors are added as CHF progresses. The ACE inhibitors are beneficial in the treatment of CHF because they prevent sodium and water reabsorption by inhibiting aldosterone secretion causing diuresis, and that decreases blood volume and blood return to the heart. This in turn decreases preload, or left ventricular end diastolic volume, and the work required of the heart, because remember, we've got a pooped pump. With ARBs and beta blocker, the therapeutic effects of the ARBs in the treatment of heart failure are related to their potent vasodilating properties, and beta blockers prevent catecholamine-mediated actions on the heart. That helps to reduce heart rate, delays the AV node conduction, reduces myocardial contractility, and helps to decrease myocardial automaticity. Aldosterone agonist and some miscellaneous diuretics are used in severe stages of heart failure to help decrease edema. So we've got spironolactone or aldactone, and then we've got some potassium sparing, Inspira, selective aldosterone blockers, and then you've got some miscellaneous profiles in your textbook. What's really important to know about the potassium sparing in comparison to loop diuretics and some of your other diuretics is that with like furosemide or loop diuretics, we have to watch potassium levels because we might actually have to give potassium because they help to decrease the potassium with loop diuretics. Whereas with potassium sparing, we have to teach them on the opposite hand of watching salt substitutes and not getting too much potassium in their diet because they are potassium sparing diuretics. So we have to teach opposite things with the potassium sparing diuretics. We did start talking about the specific hormone a little bit in patho because we measure this lab value BNP, not BMP, but BNP, to determine if it's elevated that a person may have congestive heart failure. So this is a synthetic B-type hormone that has vasodilating effects on both arteries and veins, and the effect has been shown to include diuresis, and it's used in intensive care settings as a final effort to treat severe, life-threatening congestive heart failure. It's often used in combination with several other cardiostimulating medications. It's not the first-line drug. It's very expensive. Phosphohydrase inhibitors like millerone come from the intercellular increase in cyclic adenosine monophosphate, which includes positive inotropic response in vasodilation. Inhibition of phosphohydrase results in the availability of more calcium, which helps with muscle contraction and increases the force of contraction. So, with inotropic drugs or positive inotropic drugs, we're increasing the force of contraction. If we were talking about negative inotropic drugs, we would be decreasing the force of contraction. So inotropic has to do with contraction. Chronotropic drugs has to do with heart rate. Again, positive would increase, negative would decrease. Dromotropic drugs have to do with conduction rates. Same thing, positive and negative are available. So inotropic, contraction, chronotropic, heart rate, dromotropic, conduction. So those are all terms that you need to know and understand. We will discuss cardiac glycosides at more depth later on, but digoxin or lanoxin is the most common cardiac glycoside that we give. It's the oldest group of cardiac drugs. Not only do they have benefits for heart failure, but they also control ventricular response to AFib. That's probably what we give digoxin for the most, is to try to convert AFib. Digoxin is thought to increase myocardial contractility, which would be a positive inotropic or contraction effect. And it slows the heart rate and improves cardiac efficiency. So if we're going to give digoxin, got to make sure that we take that heart rate for a full minute, and we count it apically for a full minute before we have somebody swallow that, or if we're giving an IV, or however we're giving that. And we're doing it ourselves. We're not just trusting somebody else to do it. And then we'll get into talking about digitoxicity and all of that at a later date. JS is a 78-year-old male patient experiencing CHF after abdominal surgery. He has received DIG for the past 4 days and has been progressing favorably. He's usually very alert and entertaining. He's a sports fanatic and he loves football. But when the nurse enters the room, the patient's watching a football game on television, and the patient asks, "Why are those guys hitting each other and falling on the ground?" The patient's also confused as to the date and his location. Ooh, maybe we're going to talk a little bit about digitoxicity now. So what do you think might be the cause of sudden confusion? I think I might have given that away. All right, so here's some signs and symptoms that we should talk about with digitoxicity. Bradycardia, because it does lower the heart rate, headache, dizziness, confusion, nausea, visual disturbances, which my favorite one is blurred vision and yellow vision, because some dig doses are yellow, so I always love that we talk about yellow vision. EKG findings might include a heart block, atrial tachycardia with a block, or some ventricular dysrhythmias. So like AFib with RVR, rapid ventricular rate. So things like that. So him seeing things weird might be an indication. Potassium is another thing. What laboratory test does the nurse expect to be ordered, and what outcome does the nurse expect? Well, we can actually take a dig level. The nurse expects that a serum digoxin level will be ordered, and the results will show a level of 2 or higher. 2 nanograms per milliliter or higher. A potassium level will be ordered to see if it's within normal range. Normal therapeutic levels for digoxin are 0.5 to 2. Yes, you need to know this. So you're looking for anything that is between 0.5 and 2. If it's above 2, it's toxic. Anything above 2 is toxic. DIG has a narrow therapeutic index. Minor elevations can have significant effects in NCLEX world. Because diuretics are often given in conjunction with digitalis, especially if we're giving it for congestive heart failure, and many patients are potassium losers, especially if they're on digoxin and furosemide, the presence of hypokalemia is significant. It also can increase the risk of digoxin toxicity, so we want to make sure that we're checking a potassium level as well. We need to know that 3.5 to 5 is the normal potassium level. What treatment option does the nurse expect to administer? You will be happy to know that there is this cool thing called digoxin immune fab. It's fabulous. It's an antibody that can recognize digoxin as an antigen and forms an antigen-antibody complex with the drug, inactivating the free digoxin in the body. I want you to know that I really could care less about these terms because I think they can be used interchangeably, but your book wants you to know that it's not okay to do that. So, dysrhythmia and arrhythmia are different terms. Dysrhythmia is like normal, it's a deviation from normal, whereas arrhythmia means without a rhythm, like asystole. And that would be literal. But what I have to tell you is that in the real world, you will hear these terms used interchangeably to mean a rhythm that is not normal. So we're going to talk a little bit about these, but you're going to learn so much more about these in complex care and as you go on throughout school. So there are antidysrhythmic drugs according to where they work at on the cardiac cells and how they work in different parts of electrical functioning. Class 1 are membrane stabilizing, and they exert their action on sodium fast channels. Class 2 are beta-adrenergic blockers, and they work by blocking sympathetic nervous system stimulation of the heart. And then Class 3 increase action potential by prolonging repolarization in phase 3. Class 4 are calcium channel blockers, and they work specifically by inhibiting calcium channels. And then antidysrhythmics can interact with a lot of different drugs. The most serious drug interactions are those that can result in other dysrhythmias, which, guess what? That's what most of these do, is that they can cause other dysrhythmias. Hypotension, hypertension, respiratory distress, excessive therapeutic or toxic drug effects. I am basically having you look at tables in your textbook. I'm going to point out some common ones that I want you to know. Yeah, we're going to talk about epinephrine, and we're going to talk about some certain ones that I'm like, I can't think off the top of my head, so I'll talk to you about the ones that I want you to know about on the slides. Contraindications, if they have a heart block, if they're in cardiogenic shock, if they are in sick sinus syndrome, there's certain ones you can't use. There's certain types of drugs that will make different rhythms worse. Side effects: nausea, vomiting, diarrhea, headache, dizziness, blurred vision, new dysrhythmias with prolonged QT intervals. Torsades de pointe would be a fatal rhythm. There's all kinds of different things that they can cause, so we have that going for us. So with that, there's this case study. The Tin Man is admitted to the emergency room with lightheadedness, shortness of breath, and feeling weak all over. He complains that his heart's racing. His wife is present, and she tells the nurse that they were walking outside when the patient said he did not feel well and that he was going to pass out. She relates that he sat down on the sidewalk and vomited. In the ED, the nurse initiates the ordered IV therapy and places the patient on a heart monitor. A 12-lead EKG and blood work are also ordered. The bedside monitor shows a paroxysmal PSVT, supraventricular tachycardia. The patient's heart rate is 180 beats a minute. His respiratory rate is 35 breaths a minute. The nurse asks the patient if these symptoms have occurred previously, and he nods. What is PSVT? This is a sudden onset of very fast impulses of electrical activity that cause the ventricles to beat very rapidly. It occurs periodically and can occur without warning. It may last a few seconds to a few hours. Recognizing the location of the onset of various dysrhythmias can assist the nurse in knowing what symptoms to expect in the patient and in anticipating what intervention may be required. What drug class does the nurse expect will be considered for the long-term treatment of the Tin Man? A calcium channel blocker. Calcium channel blockers are effective in treating dysrhythmias that arise above the ventricles, such as PSVT. These drugs prevent calcium ion influx across the slow calcium channels and cardiac conduction tissue. This results in dramatic effects on the AV node. So, with PSVT, the drug of choice that we use is adenosine, also known as adenocard. And while you're getting it ready, you can have your patient cough or bear down, and that can help give us a vagal response. The drug is going to chemically cardiovert your patient, and you have to give it really fast because it has a short half-life. And you have to have the patient elevate their arm, and you have to slam it and then slam a push afterwards. And then for 6 seconds, you're going to see a systole on the monitor because it really stops the heart for like 6 seconds. And then hopefully it's going to bring them back slower. And if it doesn't, after you give them 6, you're going to have to turn around and give them 12. And I do want you to know about adenosine adenocard, so look that up for SVT. 4 months later, the Tin Man is back in the ED with shortness of breath, palpitations, and dizziness. He's connected to the cardiac monitor and has the rhythm noted above. Identify the rhythm and the top nursing priorities. So that rhythm is not PSVT. That is V-TAC. Uh-oh. So what is this dysrhythmia, and what's your biggest concern? VTAC, rapid heartbeat from impulses originating in the ventricles. It can be non-sustained, brief, or sustained, requiring definitive treatment. Worsening VTAC can deteriorate into torsades de pointe, which often deteriorates into VFib, which can be really difficult to come back from. So this is not a good situation. So evidence-based treatment to save this patient's life is that we're going to give them amiodarone. It's indicated for management of life-threatening VTAC or ventricular fibrillation that is resistant to other drug therapy. It is the drug of choice. Has significant interactions with lots of other drugs. Prepares for management of sustained VTAC as well as non-sustained VTAC on all three of these. It has effects on sodium, potassium, and calcium channels as well as alpha and beta administration. Blocking properties. It has significant drug interactions with dig and warfarin. It will increase the dig levels and prolong bleeding time. The dosage of dig or warfarin should be reduced by 50% at the start of amiodarone therapy. Dig levels will increase by 50% and the INR will increase by 50% in 100% of patients taking these drugs in combination with amiodarone. While I do not expect you to know all rhythms, I think VTAC and VFib are good ones to start out knowing. You know, sinus rhythm, VTAC, VFib. So yeah, this is VFib. 45 minutes later, the tin man has the following dysrhythmia. What is the problem in priority action? VFib is fatal, if not reversed, and requires immediate electrical defibrillation and epinephrine, 1 milligram every 3 to 5 minutes IV or IO, intraosseous. After the patient has been shocked, immediately resume CPR, beginning with compressions for 5 cycles, about 2 minutes. The quicker the defib, the more likely the patient is to survive. We've gone from ABC to compressions first. Perfusion, chest compressions have been shown to be more important than providing rescue breathing and saving the patient's life. Diuretics basically remove sodium and water from the body. The huge role is for the kidneys. They have a direct effect on neurons, remembering that they filter the blood from the glomerulus at the rate at which this occurs with the GFR, the filtration rate. Small vessels regulate the afferent. A is for approach and E is for exit. This requires energy, ATP, sodium and potassium pump, to go back to the loop of Henle and distal convoluted tubule, which is regulated by aldosterone, to the collecting duct. Make sure that you review your physiology on the kidneys part for diuretics. The sites of action of the various diuretics are determined by the way in which they affect the solute or the electrolyte in the water and the transport systems along the nephron. CAISs are carbonic anhydrase inhibitors, and they are derived from sulfonamide antibiotics. And they are found in the kidneys, the eyes, and other parts of the body. Primarily, they're used for glaucoma. Loop diuretics are our most common one. They really are. They have renal, cardiovascular, and metabolic effects. These drugs are primarily along the thick ascending limb of the loop of Henle. They block chloride, and secondarily, they work for sodium reabsorption. They are thought to activate renal prostaglandins and result in dilation of blood vessels of the kidneys, the lungs, and the rest of the body. Loop diuretics are particularly useful in rapid diuresis because of their onset. And the most common one is Lasix, furosemide. That's what we use very, very frequently. They're used to manage edema associated with heart failure and hepatic or renal disease, to control hypertension, and to increase renal excretion of calcium in patients with hypercalcemia. Most common carbonic anhydrase inhibitor is Diamox, and again, it's used for glaucoma quite a bit, for open-angle glaucoma. It's contraindicated in hyponatremia, hypokalemia, renal hepatic dysfunction, adrenal gland insufficiency, and cirrhosis. It can cause metabolic acidosis, hypokalemia, drowsiness, anorexia, paresthesia, hematuria, crampian, urticaria, photosensitivity, and melena. Biggest thing to know about this one is it's for open-angle glaucoma, and it's Diamox. It's your drug. Loop diuretics. Biggest thing to know, this is the most common. Furosemide, Lasix. That's what I know about this one. And it is also chemically related to sulfonamides. It works on the ascending loop of Henle to block chloride and sodium reabsorption, to activate renin prostaglandins to dilate blood vessels on the kidneys and lungs. It helps to reduce preload. It works fast. We treat edema, CHF, hepatic cirrhosis, and renal disease. It does cause hypokalemia. So just about anybody who is on Lasix gets potassium. Some kind of a potassium supplement. Can cause photosensitivity. If you give IV Lasix, like if you give 40 milligrams, it's usually 10 per milliliter. So like if you give 40, that's 4 milliliters, which needs to be given over 4 minutes. If you give it over a minute, you can cause speed rush, and it can cause your patient to lose their hearing. It's not good, not good at all. So it needs to be given at least over a minute per mil. Contraindications: hepatic coma, if they had severe electrolyte loss, if they had low potassium, that would be a problem. You're going to give them cramps, and you're going to possibly cause some cardiac dysrhythmias. Note that we often give this in combination with potassium because it causes potassium loss. Osmotic diuretics, big thing to know about this one is that we give this one for increased intracranial pressure. Mannitol is your drug of choice. Contraindicated in renal disease and pulmonary edema, but this is what we give for people that have been in major traumatic car accidents and they've got ICP. It works along the entire nephron, proximal tubule, and descending limb of Henle by increasing osmotic pressure in the glomerular filtrate and pulling fluid into the renal tubules and surrounding tissues. We're treating increased ICP with this, and it is mannitol. That's what you need to know. Potassium-sparing drugs like spironolactone or aldactone. The big thing to know with this one is that we commonly do use it for hypertension instead of just a diuretic, but can be used as a diuretic. It can also be used for hyperaldosteronism, but it can cause hyperkalemia. Big teaching point is no salt substitute because that has potassium in it, and it can, unlike the loop diuretic, instead of it causing hypokalemia, it can cause hyperkalemia, so no additional potassium. It's contraindicated in patients who have renal failure or hepatic failure. Obviously, if they already have a high potassium level, that would be a problem. It's weaker than your loop diuretics and your thiazides. Thiazides and thiazide-like diuretics, like HCTZ, and then I've listed a few others, but the hydrochlorothiazide is the most common one. Contraindications would be hepatic coma or renal failure, so there is a theme there. It can cause electrolyte and metabolic disturbances. This one, like your loops, can lower potassium, and this one works mainly on distal convoluted tubules to inhibit reabsorption of sodium and potassium and chloride, and it relaxes arterioles and reduces peripheral vascular resistance or afterload. It treats congestive heart failure and hypertension. So hydrochlorothiazide or HCTZ is your most common thiazide-like drug.
Glenda the Good Witch is seeing her nurse practitioner today for a follow-up appointment. 2 weeks ago, she was seen for complaints of occasional headaches. On that visit, her blood pressure was 160 over 110. She has been monitoring her blood pressure for the past 2 weeks, and it has remained 150 over 100 or higher. She is not overweight, does not smoke, and walks for exercise at least 3 times a week. The nurse practitioner decides to start her on therapy with spironolactone daily to control hypertension. What the nurse and the patient need to know. What is the role of spironolactone in the treatment of hypertension? It's a potassium-sparing diuretic that binds to aldosterone receptors and therefore blocks the reabsorption of sodium in water. And it's important to understand the role of how medication treats disease. The patient asks what diet changes she will need to make. Well, if this one's potassium-sparing, we're going to have to watch potassium. Tells her that she needs to limit her potassium intake. And we're talking about bananas, oranges, apricots, dates, raisins, broccoli, green beans, potatoes, tomatoes, meats, fish, wheat bread, legumes. We're also going to talk about salt substitute. As the patient is leaving the office, the nurse overhears her talking on the phone, says, "I'm having terrible cramps. I can't wait to get home and take some Tylenol. Is there any further patient teaching necessary?" No, the patient can take acetaminophen for pain without having any drug interactions with spironolactone. Concurrent use of non-steroidal anti-inflammatory drugs such as aspirin and ibuprofen will result in decreased diuretic effects and should be avoided. NSAIDs can inhibit renal prostaglandins, which decrease blood flow to the kidneys and decrease delivery of diuretic drugs to the site of action. So that can lead to diminished diuretic response. So they should avoid NSAIDs, but they can take Tylenol. The patient calls to the clinic and tells the nurse that she's having a lot of diarrhea a week later. Her legs are so weak, she's having trouble putting one foot in front of the other. She's been very irritable. Her husband insists she calls in. What does the nurse suspect? I think she might be having some hyperkalemia. Hyperkalemia can occur when taking a potassium-sparing diuretic. Time waits for no man to keep the ticker healthy. And so I've gone over a lot of things in this lecture. You really have everything you need to know. With beta blockers, it's important to understand the concept of bronchoconstriction. You need to know a lot about hypertension and safety issues with this, and patient teaching with this, and diet and exercise, and some basics on that. You need to understand monitoring blood pressure with nitro. You need to understand the DIG level and what a toxic level is. You would need to be able to recognize a drug from the calcium channel blocker class. You need to be able to recognize what the antidote for DIG toxicity is. You need to be able to recognize the drug of choice for increased intracranial pressure. You need to be able to recognize a drug from the most common classification of diuretics. And you would need to recognize a side effect from furosemide. And that's what I have for you. Good luck and happy studying.